Hello everyone, today we are going to be discussing taking a sexual history. Before we begin to introduce the skills of taking a sexual history, let's review the data from the CDC. In the past 5 years, the US is experiencing a sustained increase in sexuality transmitted disease. From the year 2013 to 2017, the combined diagnosis of chlamydia, gonorrhea, and syphilis increased around 31%. In the year 2017, chlamydia was the most common condition reported to CDC. Let's see the data from China. In the year 2014, around 500,000 people living with HIV. Around 150,000 new cases were reported, and 21,000 AIDS-related deaths were reported, and around 300,000 cases were on antiviral treatment. However, the diagnosed cases only represent just a small portion of the true disease burden. The undiagnosed STDs can lead to severe health problems, such as infertility, ectopic pregnancy, and increased HIV risks. Therefore, the dramatic rise of this disease is a reason for clinicians to better understand patients' sexual practice and preference. As medical students, now it's time to hone better sexual history taking skills. Based on the learning objectives of this lecture, I hope at the end of this session, you will be able to describe the reasons of taking a sexual history, understand the communication skills of taking a sexual history, and you will be able to know the approach to taking a good sexual history. Why it's important to talk about sex? Although it may be easier to communicate with patients about their sexual problems with a specialist, in many circumstances, patients go to the doctor's office to discuss sexual problems. The doctor and medical students working in a wide range of settings need to acquire some basic skills that enable them to take sexual history. Assessing sexual health is an essential part of comprehensive health exam. A sexual history needs to be taken during a patient's initial visit, routine preventive exams, and when a patient presents with signs and symptoms consistent with STD. Let's see a case. This is 67-year-old gentleman. He was diagnosed as candida dermatitis, and he was referred to the Department of Dermatology, but the lesions were not resolved. The RPR test was negative. RPR test is a specific test for syphilis. The rash was 4 to 6 weeks old, mildly pruritic. The lesion studied as small villous then crust. And the biopsy results show lichenoid interface dermatitis with plasma cells. The features are not classic for secondary syphilis, but it cannot be entirely ruled out the diagnosis. Then, after 2 weeks, you can see in the picture the patient presents new lesions with small blotches or indented circles, which are typical skin lesions of syphilis. Then he checked the RPR test again. Then this time the test was positive. So for this case, sexual history has not been done until the patient develops classic syphilitic rash. The patient has been seeing specialized providers for many times. However, it's important to note that many STDs have various incubation time, and we also call that vital periods. Hence, the symptoms and signs may be delayed, and the infections are commonly asymptomatic. So relying on report of symptoms is not adequate. Then, how do we know if our patients are at high risk of STD or HIV? Yes, the sexual history. Sexual health is fundamental to the physical, emotional, and social health of individuals, families, and communities. The purpose of taking a sexual history is to prevent of STDs diagnosis and treat symptomatic disease, is to identify sexual dysfunction and association of sexual health with common problems such as anxiety, depression related to a history of sexual abuse, and sexual health is associated with the quality of life. And the second question will be when to talk about sex. Should we take sexual history for all the patients in the clinic? Although there are advantages and disadvantages for the doctor to take the sexual history from all the patients, actually, it could be very difficult. It could be a dilemma to whether it's timely to take a sexual history from all the patient. Look at this picture. The patient went back to a general practitioner's receptionist to make a new appointment and said, I don't want to see him again. I only went in with a cold, but the doctor asked me all about my sex life. The advantages for the doctor to take sexual history, the sexual problems are seen as normal part of the sexual or problems discussed with the doctor. Then, by us talking about sexual issue, even when they are not seen as problems, you may open a door for future consultations about sexual problems. Then the discussion about sexual activity can be a opportunity for health promotion. However, it could be very difficult. It may be embarrassing for the patient and the doctor. The patient may misunderstand the purpose of the discussion and feel his or her lifestyle is being judged. The patient may begin to worry about something that was not previously a problem. Then, when to talk about sex. The first situation when the patient presents with a problem that is likely to be sexually related. Say, for example, the patient may present symptoms such as genital discharge, which may lead to a discussion with the doctor about the past sexual activities. The patient may require a physical examination and counseling about reducing further risks to STD. The patient may present anxiety about sexual performance that might also present to the doctor in this context. The second situation could be when patients have medical or social problems that may lead to sexual difficulties. Sexual problems may be associated with other medical or social problems. Say, for example, impotence may result from diabetes. As the patient with HIV may worry about disclosure of his status to his partner when starting a new relationship. This slide is from your textbook showing the guidelines for talking about sex. You may evaluate the patient whether the patient presents any medical problems that is sexually related. If it is, then start taking a sexual history. If it's no, then you may evaluate the problem that may have any implications for sexual functioning, such as impotence, such as infertility or depression. If it is, then normalize the problem in relation to sex and give the patient the opportunity to discuss any concerns. If it's no, then if possible, then discuss safer sex in the context of HIV and the other STD prevention and clarify that you do this with all patients. However, there are barriers for the patient and the doctors to initiate a conversation about sex life. The emotional factors. Patient may feel ashamed at having to ask for help with a sexual problem that they think is private and they should cope with themselves. This is particularly true with men, especially the young men. The perception that sexual functioning is not an important medical problem. Lack of awareness about treatment possibilities. The other barriers could be physician factors such as gender, age, specialty, and cultural rules. The involvement of the doctor's office. Limit office hours, poor communication by the provider, and lack of provider knowledge and skills, lack of privacy, lack of confidentiality, etc. The barriers for the doctor. When I was a medical student, we don't have this kind of course of communication skills. The barriers usually include lack of knowledge and skills regarding sexual problems, insufficient or inadequate communication, and we should get over the initiate embarrassing, especially if the patient wants to talk about things that are outside the doctor's experience, because this will cause the patient to stop to climb up. The patient could be very busy, assume that this should be someone else's task. There are also some assumptions and misconceptions about sexuality and lack of awareness of the comorbidities of the sexual problem. Then we're going to be discussing tips in sexual history taking. Sexual health is defined by the WHO as a state of physical, emotional, mental, and social well-being in relation to sexuality. For sexual health, it may encompass a wide range of topics, including knowledge about anatomy and function, sexuality, sexual identity, sexual orientation, and gender, reproductive health, and fertility, and sexual violence. The first place could be privacy and setting. To make your patient feel comfortable, ensure there is privacy so that the conversation can be seen to be confidential. The environment should be welcoming and comfortable, but conversation should take place in private and behind the soundproof doors. Partners or relatives may prevent the patient from revealing personal information, ideally seeing the patient alone. Clinicians should feel comfortable discussing sexual matters with patients. If you feel uncomfortable, you might prefer to identify the patient's problem and suggest the patient is interviewed by someone else. For personal safety, be preferred for more than one person to present during the conversation, particularly if there is a suspicion that the patient becomes violent or abusive. Look at this picture. Placing seats at the side of desk is a more friendly arrangement for the interviewed. It will make it easier to observe the patient's body language and give clues for the underlying relationship. Pay attention to the patient's body language, such as their use of their hands and arms. Uneasily twinkling with a ring, defensively crossing arms, protectively holding a bag on a lap, which may reveal their state of mind. Postural echo. When doctor and patient see immediate images of each other's position, that may indicate empathy and harmony between the speakers. Another important issue could be choice of terminology. One difficulty that bothers many doctors is whether to bring terms into the discussion because they are emotional touch, and some doctors will only use medical terms. Patients too, because of embarrassing about using street language and fear of causing offense, may try to express their problem in medical terms, but get the meaning wrong. Both can cause problems in getting an accurate history, but doctors must use very careful judgment in deciding if it could be more appropriate to use the language of streets. The confidentiality. Patients should be assured of confidentiality. The duty of confidentiality should be explained to the patient verbally, but also reflected in patient's literature. In specialist clinics for treatment of STD, legislation protects additional confidentiality. Another issue, whether the doctor should disclose the patient's HIV positive status to the patient's partners. The answer is yes. According to the national and local policy in China, HIV status disclosure to the sexual partner can help HIV prevention and enable HIV positive people to receive social support. Assure the patient that the medical history is confidential. If patient express concern during the history, provide information after they disclosure information. Say, for example, you can say, I'm glad you told me this. I know this wasn't easy for you to tell me, and I appreciate your honesty. Assure patient that information related to sexual identity or behavior will not be shared with parents, spouse, partner, or other family members. Always ask for permission and explanation. Only ask for the information that you need to mention the patient. Avoid intrusive. Questions should be asked in a matter of fact. Explain why you need to ask the questions, for example, to assess the risk of STD. Another person should be present if the patient requires intimate physical examination. The communication skills after appropriate greeting, observe and reassure if possible. Maintain eye contact is crucial. Patients are often weak. Listen and watch to ensure you have understand and whether you need to ask further questions to confirm. Nonverbal cues are particularly important. Try to use neutral terms such as person or partner, but not boyfriend, girlfriend, wife, and husband. Avoid assumptions. Be open to what patients may tell you. Encourage patients to talk. You can say in your own words. To be active listening. Maintain eye contact and nodding. You can say yes, go ahead. Choice of terminology is very important. Be clear if discussing sexual behaviors. Ensure that the patient understands any medical terms you may use and that you understand their language. Try to use open questions to initiate the conversation, clarified with closed questions if required. I think you have learned what open questions and closed questions. Try to start with open questions. Say, for example, how can I help you? Then continue. What is your problem? What do you think caused the difficulty? Give the patient opportunity to understand and say what is really bothering them. Do not use judgmental questions such as, confusing your past, that sort of things, not avoid, try to avoid. Close question is a specific answer, such as yes or no. And you can say, have you had the list problem before? The silence is a very powerful tool in taking a good sexual history for the best interviews. However, many doctors find it extremely difficult not to practice silence, speaking too much because they are embarrassed by the quiet or feel it's rude not to say anything. However, it's very important for the patient allow the time to contemplate their thoughts and try not to interrupt their thoughts by an inappropriate statement. The last one could be tactful and respectful. If the patient is not a native speaker, try to allow capacity to accommodate and communicate with unrelated translator. This slide shows an example of open questions. Try to remain non-judgmental. Avoid moral or religious judgment of their patient's behavior. Human sexual behavior is diverse. Just concentrate instead of managing your health-related needs, including psychological and emotional, and take time to address the patient's concern and anxiety. Sometimes the patient may require the clinician's gender on cultural or religious grounds, or due to the personal preference, should be accommodated whenever possible. Recognize the doctor's own bias on cultural or religious grounds. Avoid value lender language, such as you should do something, why didn't you do something, I think you should do something. Another example, a 16-year-old boy was struggling to find medical words to explain his anxiety about masturbation and ejaculation. When the doctor tried to help him out by using street language, the boy looked startled and said, I didn't know the doctor knows these words. The rest of the conversation was much more relaxed and informative. So try to be clear to understand what the patient is talking about and let the patient understand your language. Repetition is another powerful technique to get a patient to elaborate on what he or she is trying to say. It's very easy. These are the example. Without repeating, doctor, I think I need a checkup. Yes, of course, it's quite a time since the last one. Then let me start with your blood pressure. Then you compare with this. Doctor, I think I need a checkup. You said, checkup, yes, I'm not performing as well as I used to. Performing, yes, you know, then, but I feel so guilty and ashamed. Then you said, ashamed, I feel terrible. Then you think repetition elicits much more information. I have introduced the important skills of taking a sexual history. Then I will move on to introduce the content of a sexual history. The components of sexual history. As the complete medical history, the sexual history also includes the chief complaint, the nature of previous sexual activity, the history of pregnancy, miscarriages, conceptive or barrier protection methods, history of other sexuality transmitted disease, relevant risk factors such as travel away from home, alcohol and smoking use, allergy, and medications. History of sexual abuse. I have mentioned sexual health is physical, emotional, and social health of individuals and families. So you may also include psychological problems, psychosexual problems, cultural and religious rules and practice, and partners' conditions in sexual history. Recommended by CDC, there are 5 P's of taking a sexual history: the partners, the practice, protection from STDs, past history of STDs, and the prevention of pregnancy. The other components of sexual history. Social history. Social history helps the doctor to put the patient into context. The patient's problem can be the first item to be discussed. By taking a social and medical history before the problem allows the patient time to relax, while talking about the familiar things such as children, the home, and so, and enables the doctor to put the problems into perspective. The medical history is very important to take medical history because many diseases may affect sexual performance. For example, diabetes can eventually cause impotence. Depression will cause loss of sexual desire. Heart disease, especially when combined with hyperlipidemia and the other disease, can cause for ED in many men. Other hormone deficiencies such as thyroid may reduce sexual desire and performance in both sex. Operation and trauma, especially gynecologic and prostate, can cause problems. Damage in the pelvis or spine is another important cause. Pain or arthritis in older women can be very common for the this issue. The other components of sexual history, patients and the partner's view of women. Marital dysfunction could be a major cause of impotence. It's very useful to try to assess the complex relationship just by looking at their body language to each other. Medical and recreation drugs. Many drugs, especially antihypertensive drugs, the quantity and frequency of alcohol use and smoking or nicotine intake can have a profound effect on sexual performance. We will discuss the procedure of taking a sexual history. Beginning the sexual history, introduction and handshake. Begin the sexual history by reassuring the patient that is a routine part of the history that is strictly confidential. Learn the chief complaints. Check the patient's reason for attending. They may require advice or checkup, or they may have specific symptoms. Where symptomatic, check the duration, the nature of any reported symptoms, as we have done in the medical history taking. For review of the symptoms, for women, try to inquire the vaginal discharge, valvular skin problems, lower abdominal pain, dysuria, changes in MC or irregular bleeding. For male, you can inquire the urethral discharge, dysuria, genital skin problems, testicular swelling or discomfort, perianal and anal symptoms. Proceed with the 5 Ps. The first will be partners. You can ask, in the past 6 months, how many sex partners have you had? On the sex partner, man, woman, or both. Any partners know to be HIV positive? How many partners know to be HIV positive? It will be practice. Then you can say, I'm going to be more illicit here about the kind of sex you have had over the last 12 months. To better understand if you have any risk factors for STDs, then you can ask what kind of sexual contact the patient had. The third P will be the protection from STD to evaluate the risks of acute STD or the HIV infection in all patients. And the past history of STD, then you can inquire, have you ever been diagnosed as STD such as HIV, such as gonorrhea, chlamydia, syphilis? And how were you treated? Did you take the medications? Have you had any recurring symptoms or diagnosis? Have you ever been tested for HIV? When was your last HIV test? What was the result? Has your current partner or any former partners ever been diagnosed or treated for an STD? Were your tests for the same STD? If yes, when were you tested? What was the diagnosis? How was it treated? Patient and you inquire the prevention of pregnancy. Are you currently trying to conceive a child? Are you concerned about getting pregnant or getting your partner pregnant? Are you using conception or practicing any form of birth control? Do you need any information or birth control? Have you used emergency conception in the past year? If so, how many times? Also, to check the menstruation history, any menstrual abnormalities, and in related to the cycle is established if there is possibility of pregnancy. Additional question to identify the HIV and hepatitis risks. You can ask, have you or any of your partners been diagnosed with HIV or hepatitis B or hepatitis C? Have you and any of your partners ever inject drugs? Have you and any of your partners been diagnosed using drugs or after drinking alcohol? Have you had a hepatitis B vaccine, hepatitis A vaccine? Have you ever taken the pre-exposure prophylactics to avoid getting HIV or taking post-exposure prophylactics to prevent against HIV? In addition, try to inquire on past medical history, surgical history, color medications, allergies, HPV vaccination history, history of cervix cytology in women, and smoking, alcohol use, intravenous drug use with needle sharing, and last use. This slide shows the other questions you can ask to your question while you are taking the sexual history. Bring the sexual history, you can ask, is there anything else about your sexual practice that I need to know about to ensure your good health care? And you can also ask, are you or your partner having any sexual difficulty at this time? Do you have any sexual concerns you could like to discuss? Actually, try to do some health promotion. Taking the sexual history, thank the patient for being open and comment any protective practice. For patient at risk of STDs, encourage testing and offer praise for protective practice. For patient at risk of pregnancy, offer praise for consistent conceptive use. After reinforce positive behavior, address specific high risk practice. Reassure the confidentiality and tell the patient who will assess the medical records. Again, the learning objectives of this lecture. At the end of this lecture, I will show some examples of taking a sexual history, some good practice and bad practice. Try to make comments.
Watch as this provider takes a sexual history from a female patient. What do you think the doctor could have done better?
Hi, I'm Dr. B. Are you Sharon Morgan?
Yes, I'm Sharon.
Well, you'd like to be called Sharon?
Yes, please.
Okay, so what brings you in today?
Well, I just started dating someone new, and I'd like to get STD testing done so that I'm good to go.
Okay, do you know when the last time that you were tested for HIV?
I think it was about 2 years ago.
Did you also get tested for other STDs?
I think so.
Okay, so you have sex with men?
Mostly, sometimes women. I like exploring.
So you're bi?
I guess.
All right, so I'm just gonna ask you about condoms. You always use them, right?
Most of the time.
Good, that's good. You mentioned you had a new partner. How long have you been sexually active with him?
Derek, about 3 months.
And including him, how many partners have you had in the last year?
3.
Are you currently using contraception?
Just the condoms. I had taken birth control, but I stopped about a year ago because it made me feel bloated and I kept missing it.
Oh, that's too bad. Have you ever been diagnosed with an STD?
No.
Do you use any drugs?
I smoke cannabis.
How about cigarettes?
No.
And alcohol? Do you drink alcohol?
Socially.
Sharon, any other medical problems, medications you take, allergies?
No.
All right, well, anything else you want to let me know about?
No.
So let's get these tests done. But before we do, just a couple of thoughts that I had. You know, if you're not going to use contraception, it's really important to use condoms all the time. You don't want to get an STD or get pregnant, do you?
No.
What did the provider do that limited their ability to collect a complete sexual history? What could they have done differently? We noted. They did not elaborate or offer examples when the patient was not sure of a question. They did not question or elicit more details in examples of STD testing, types of sex, other partners, condom frequency, or drug use. They made assumptions about the patient's behavior. They asked presumptive, closed-ended questions. They were judgmental. They missed opportunities to educate and discuss HIV prevention strategies, including PrEP. And their advice was critical and unrealistic and did not engage the patient. Here's a more comprehensive and open way of taking a sexual history.
Hi, I'm Dr. B. Are you Sharon Morgan?
Hi, yes I am.
Is that what you'd like to be called?
Yes, please.
What pronouns do you use?
She and hers.
That's what I used to. What brings you in today?
Well, I just started dating someone new, so I'd like to get some STD testing done so that I know I'm good to go.
Are you having any current symptoms?
No, I'm not.
Okay, just want to make sure. Any fevers, weight loss, throat pain, rash,
Oh, no.
discharge, pain when you go to the bathroom?
None of that.
Okay. And do you remember the last time you were tested for HIV?
About 2 years ago?
Did they test for STDs as well?
I think so.
What samples did they take?
Blood tests.
Did they do any swabs of your throat, vagina, or rectum?
No, but I did go to see my gynecologist 6 months ago, and we did a pap smear.
So who do you have sex with?
Mostly men, sometimes women.
Do you consider yourself bisexual?
No, more so pansexual. I like exploring.
Nothing wrong with that. What types of sex do you have?
Vaginal?
How about any oral sex or anal sex?
Oh yeah, oral. I've had anal sex, but not recently.
How often do you use condoms?
Most of the time with a new partner, but then after we get comfortable with each other, they kind of go away. All
right. You mentioned that you have a new partner. How long have you been sexually active with them?
Derek, about 3 months.
Okay. And are you sexually active with anyone else right now?
Not currently, no.
What types of sex are you having with Derek?
Vaginal and oral.
And including him, how many partners have you had in the last year?
3.
Are you on contraception right now?
Just the condoms. I had taken birth control, and I stopped about a year ago because it made me feel bloated, and I kept forgetting to take it.
Yeah, that's no fun. Are you interested in taking a different contraceptive method?
Possibly. I just don't want side effects.
Here's when the provider would discuss contraception, which is not covered here.
Have you ever been diagnosed with an STD?
No.
Do you use drugs?
I smoke cannabis.
Okay. Anything else?
No, I tried ecstasy and coke once a couple years ago, but nothing recent.
Okay. And have you ever injected drugs?
No.
Do you smoke cigarettes?
Nope.
How about alcohol? Do you drink?
Socially.
How often?
On the weekends, 1 to 2. I really don't drink that often.
Okay. And do you have any medical problems I should be aware of?
No.
Do you take any medications?
No.
Any allergies? It's pretty easy for me. Do you have any questions for me? No, I don't. Okay. And is there anything that you wanted to share that I didn't ask you about? Okay. So let's get these tests done. Just have one question for you before we do that. Have you ever heard of PrEP or Truvada?
I've heard of PrEP. That's the pill that gay men take to prevent HIV.
Yeah, that's right. Gay men do more often take it, at least in the United States. But it's actually for anyone who's sexually active who might be at risk for HIV.
Do you think that I'm at risk for HIV?
Based on what you've told me, I don't think so. But I like all my patients to know what their options are for them and for their partners and friends.
Okay, well, thank you. I'd like to hear more.
Great.
What did the provider do to make the patient feel comfortable and allow for more open dialogue? We noted they provided examples when the patient was unsure about an answer. They followed up at times during difficult questions. They did not make assumptions or judgments. They matched the patient's language. They used open-ended questions. They opened up the dialogue to discuss HIV prevention strategies and PrEP. If there is time, you can also ask the patient about where they met their partners, if they discussed HIV STI testing with their partners, or if they exchanged sex for goods. You should also discuss what tests you are performing. Watch as this provider takes a sexual history from a male patient. What do you think the doctor could have done better?
Hi, I'm Dr. B. Are you James Abbott?
Yes.
What would you like me to call you?
You can call me Jimmy.
Okay. So what brings you in today, Jimmy?
I'd like to get STD tested.
Okay. Are you having any current symptoms?
No.
When was the last time you tested for HIV?
About a year ago.
Were you tested for other STDs as well?
Yeah, I think so.
So you sleep with men?
Yeah.
What kinds of sex do you have?
Oral and anal.
Are you assertive or receptive?
What do you mean?
Are you the top or the bottom?
Oh, I do both.
And you always use condoms, right?
Well, like half the time.
Okay. And how many partners have you had in the last year?
About 50.
You said 50?
Yeah.
Okay. And where do you meet most of your partners?
Mostly at the bars, some of the phone apps.
Have you ever been diagnosed with an STD?
Yeah, but it's been a while. I think it was chlamydia.
Do you use any drugs?
I smoke cannabis sometimes.
And how about alcohol? Do you drink any alcohol?
Socially.
Do you smoke cigarettes?
No.
Do you have any medical problems? Do you take any medications? Do you have any allergies? Is there anything else you want to tell me?
I mean, I take a multivitamin.
Okay. Well, let's get these tests done. Before we do, just a couple of things I wanted to discuss with you. So you really should be using condoms all of the time. You said 50%. It should be 100%. You really always want to use them. And also, you mentioned a lot of partners. I think toning down the number of partners you have, because you're at really high risk for getting an STD or HIV.
Okay.
What did the provider do that limited their ability to collect a complete sexual history? What could they have done differently? We noted they did not elaborate or offer examples when a patient was not sure of a question. They did not ask questions or elicit more details. For example, types of STD testing, condom frequency, partner status, drug use. They made assumptions about the patient's behavior. They were too technical with medical terms. They asked presumptive, closed-end questions. They were judgmental. They missed opportunities to educate and discuss HIV prevention strategies, including PrEP. Their advice was critical and unrealistic. They did not engage the patient. Here's a more comprehensive and open way of taking a sexual history.
Hey, I'm Dr. B. Are you James Abbott?
Yeah.
Is that what you'd like to be called?
You can call me Jimmy.
All right, great. What pronouns do you use?
He and him.
I use she, hers. So what brings you in today?
I'd like to get STD tested.
Okay. Are you having any current symptoms?
No.
So I just want to run through a few. Any fevers, weight loss, rash, sore throat, discharge, pain when you go to the bathroom, any of those things?
No.
Okay. So when was the last time you were tested for HIV, Jimmy?
About a year ago.
Were you also tested for STDs at the time? Do
Yeah, I think so.
you know what samples they took?
Well, I think they took a mouth swab and some blood and urine.
Okay. Did they do a swab of your throat or of your butt?
Oh, yes, they did.
Okay. So who are your partners?
Well, I sleep with men.
Okay. Any sex with anyone else?
No.
What types of sex do you have?
Oral and anal.
Are you top or bottom, both?
Both.
And how often do you use condoms?
Most of the time.
What percentage of the time does that mean?
I guess like 75%.
Okay. And how many partners have you had in the last year?
Around 50.
How about in the last 3 months?
Like 10.
Where do you meet most of your partners?
Mostly at the bars, sometimes on the phone apps.
Do you ask your partners about their HIV status or if they have STDs?
Yes, all the time.
Okay, good. And have you ever been diagnosed with an STD?
I think I have chlamydia.
Okay. Were you treated for that?
Yes.
And do you remember what they gave you?
They gave me some pills.
Okay, that makes sense. Have you ever engaged in sex for money, drugs, or anything else?
No.
Okay, thanks for answering that. Speaking of drugs, do you use any?
I smoke cannabis sometimes.
Anything else?
Well, during sex, sometimes I use poppers.
And have you ever injected drugs?
No.
Do you smoke cigarettes?
No.
How about alcohol? Do you drink?
Socially.
How often?
On the weekends,
And how many drinks per night?
maybe 2 or 3.
Do you have any medical problems?
No.
Any medications that you're currently taking?
No, but I take a multivitamin.
Okay. Any allergies to any medications that you're aware of?
No.
Anything else you wanted to tell me that I didn't ask you about?
No.
And do you have any questions for me before we go further?
No, not today.
All right, great. So let's get these tests done. But before we do, I was just wondering if you'd heard of PrEP or Truvada, sometimes people call it.
Yes, I have.
That's great. Where have you heard about it from?
My friends.
Is it something that you might be interested in?
Sure, but I'd like to learn more.
Okay, we can do that.
What did the provider do to make the patient feel comfortable and allow for more open dialogue? We noted they provided examples when the patient was unsure about an answer. They followed up at times during difficult questions. They did not make assumptions or judgments. They matched the patient's language. They used open-ended questions. They opened up the dialogue to discuss HIV prevention strategies and PrEP. If there is time, you can also ask the patient about where they met their partners, if they discussed HIV STI testing with their partners, or if they exchanged sex for goods. You should also discuss what tests you are performing.
Hi, Marco. I'm Vanessa, the nurse practitioner you'll be seeing today. How are you doing?
Okay.
Okay, before we start, I just want to let you know that anything we talk about here today will be kept confidential. And if any of the questions I ask you make you feel uncomfortable, you don't have to answer them. We'll just move on. So what brings you in?
Well, I just want to be sure I don't have anything.
So anything in particular make you think you might have something?
No, just to be on the safe side.
So no symptoms, no call from anyone saying she might have a sexually transmitted infection?
No, nothing like that. But to be honest, I've been going out with my girlfriend Rosa for about 2 years, and God, I made a huge mistake. I went out to a party and I met a girl, and before I see my girlfriend again, I just want to know. I mean, I don't want to give her anything.
And when was that with the other girl?
About 3 weeks ago.
Okay, Marco, let's go over your sexual history form in more detail. This will help me decide what tests we should do. I know these are some pretty personal questions, but it'll help give you the care you might need. Okay with you?
Yeah.
So, have you ever had a sexually transmitted infection in the past?
Well, I had crabs once, and sometimes I get itchy spots, on my penis.
Tell me more about that.
Well, a girl I was with a few years ago had crabs, but I didn't know it. I guess, I was a little bit careless and I was younger, and I just sort of didn't.
A few more questions. So, you've told me about some of the sex partners you've had. Have you ever had sex with a man?
No, just women.
And you've been with your girlfriend Rosa and just this one other girl in the past year?
Yeah, that's right.
Any concern that Rosa may have had sex with someone else in the past 12 months?
No, we're pretty close, and she's really honest. I'm sure she wouldn't have slept with anyone else. As a matter of fact, after the party, I asked her, and she said no. But she didn't ask me, though.
Well, it's good you came in to get checked, because some sexually transmitted infections don't have any symptoms. So let me ask you, what kinds of sex did you and the other girl from the party have? Vaginal sex, anal sex, oral sex?
Just oral sex.
And did she give you oral sex, or did you give her oral sex, or both?
She gave me oral.
With your girlfriend, what kinds of sex do you have? Vaginal sex, anal sex, oral sex?
No anal sex, but everything else, though.
Do you use condoms with her at all?
No, we were just supposed to be with each other, and she's on the pill. I really screwed up.
I know this is difficult, and it sounds like you know that condoms are good protection in the future in case anything like this happens again.
No, this is not going to happen again. In the past, I've always been so careful about who I was with.
Tell me what you mean by that.
Well, I never slept around. I always want to get to know the person first, and I always asked if they had anything.
Well, keep in mind that a person may have a sexually transmitted infection or HIV without knowing it. So what do you think about using condoms in the future?
Well, I really don't want to, but I don't want to give anything to someone else or get anything. I really don't plan on screwing around like this again.
That's great. But please do remember that condoms really do offer great protection, and it's always good to have a few around, just in case. So we'll do a chlamydia test today, because chlamydia is very common, and most people don't have any symptoms, so you might not even know if you have it. And we'll do an HIV test. We're testing everyone for HIV, unless you don't want to. Have you had an HIV test before?
Well, I gave blood in college once, and they're supposed to test you for that then, right? I don't know, I hadn't heard anything.
Yes, they do test the blood. And if you didn't hear anything, it's pretty safe to say you were negative then. But if that's your only HIV test, you wouldn't know if you've gotten it since then.
Oh, man, that would really freak me out if I had this whole time and didn't know it.
Yeah, that would be hard. The other thing I want to talk to you about related to HIV is that the virus is also spread through sharing needles. What's been your experience using needles or drugs?
Sometimes I've used weed and cocaine, but no needles. A girl in college did, though.
Was that someone you had sex with?
Yeah, but I didn't know she was doing it until after we had sex, though.
How long ago was that? And were you using condoms with her?
That was about 4 years ago. We only did it a few times. Did we use condoms? Yeah, I think so.
So, Marco, you'll probably have to come back again to get tested for HIV. The test today won't tell us whether you've gotten HIV in the past.
This clinician had a very welcoming style, and she took things pretty slow. Men in general have had less experience interacting with healthcare providers around issues of sexual health and can often feel quite uncomfortable and guarded. And this clinician spent a good amount of time really reassuring him and allowing him to proceed at his own pace. She also asked permission to do more sensitive questioning, which I think really contributed to him being able to disclose more information to her. Although the clinician did assess his sexual partners later in the interview, at the initiation of the interview, she assumed he was heterosexual, asking him in almost a joking way if he had received any phone calls from any woman telling him that he'd been exposed to an infection. Instead of asking if he had received a phone call from a woman, she just could have asked if he'd received any phone calls. This client obviously feels very uncomfortable with the fact that he had an outside partner, and the clinician was very reassuring and and non-judgmental about that, validating that he did feel bad about it and encouraging him to take the steps he needed to take to protect himself and his partner.
I thought this clinician did a great job of not reacting and not being judgmental when the client discloses infidelity with his girlfriend. Because staff are so concerned about preventing the spread of STIs, we might be tempted in this situation to screen this gentleman even though he said that his partner does not have other partners. But I do think that we should take his word at face value and base our screening recommendations upon his response to the question. When the clinician asked this client, what's your experience been with injection drugs, this really opened the door for him to talk about any range of experience that he's had, as opposed to asking a closed-ended question where he could only give a yes or no response. It would be really important for this clinician to talk to this client about what he would do to reduce the risk of transmitting STIs or HIV to his girlfriend while he's waiting for his test results. In this case, screening for gonorrhea and chlamydia would definitely be indicated. Even though this client has been in a monogamous relationship for 2 years, he did have unprotected oral sex with a woman whose disease status he didn't know. And because gonorrhea and chlamydia can be transmitted orally, it would be important for him to be screened for these diseases as well.
HIV testing would not be indicated based on this last contact with an outside partner where he only had oral sex. However, it may be indicated due to possible exposures since the last time he was tested in college.
That concludes the part of taking a sexual history. The more you practice during training and residency, the stronger your skills will be when you need to use them. If you have any questions, please don't hesitate to send email to me. Thank you.